Welcome to the year-end program on diabetes mellitus management by medical nutrition therapy. It is the part of the postgraduate lectures we have planned for our students and ex-students. Commonly, this is a long question in postgraduate exams, particularly in December exams. We have aimed for it. It is inspired by the Nature Review Endocrinology, the review article which has come as the medical nutrition therapy in management of type 2 diabetes. It is an important article. We have inspired by it, but we don't vouch we are from that only. Lot of effort has gone in to consolidate and present in a writable form to our postgraduates. I will particularly request the students to concentrate on the key concepts, that is learning the epidemiology. It is very important. How big is the problem? Comprehend the medical nutrition therapy in glycemic control, how it helps, what are the level of evidences, and how different strategies differ. Compare different dietary strategies. One shoe never fits all. All patients are different, and that is why the key concepts, unless given to the bedside, it does not serve purpose. Identify the mechanism of metabolic benefits and apply the personalized plan. That is very, very important. Personalized plan is important. We will come to that as we progress. The global burden of type 2 diabetes 48% by 2045, and most of them require personalized care. That is why this lecture is of importance, because it requires the glycemic control, adequate lifestyle support, and comprehensive well-being. This is the aim on which we all are working. Pathophysiology, it is revisiting only. Hyperglycemia causes beta cell dysfunction. Similarly, insulin resistance causes the hyperglycemia, and this hyperglycemia further depletes. This vicious cycle continues, and type 2 diabetes is there. So, what are the things happening at the molecular level? Impaired insulin signaling, GLUT4 translocation defect. That is why the attachment of the molecules at the thing beta cell is not happening. Beta cell dedifferentiation occurs as the lipotoxicity, glucotoxicity builds up, and aging also is important. And chronic hyperglycemia further to glycates the proteins, and it causes the vicious implementation. The AGE is the static metabolic impeder to the glucose metabolism, and that is why we have to have a concept of lipo and glucotoxicity simplified, so that we have to clean the system so that the newer things can be prepared. Medical nutrition therapy is the cornerstone. This is very important thing I want to tell you, because this is the one which is to be given first and adequately, and it helps many ways, not only one or two. Diabetes in such, its complication, and particularly deadly complications such as cardiovascular health and renal health and the ocular health. When you come to the level of evidences, you see in 2022, two large societies, American Diabetes Association and European Association of Diabetes, they came out with this paper which emphasized that the medical nutrition therapy must be adequately given, and then after the another intervention should be given. In 2024, again, American Diabetes Association, American Endocrinology Association, American Academy of Nutrition and Diabetes, American College of Physician, which is our body, American Academy of practitioner nurse, and all American Pharmacists Association. They congregated and came with the guidelines about the nutritional diet, which we are adhering to today, and which is published with great scientific churning. Evidence-based strategy, the most common one you are aware of is the Mediterranean diet, in which the whole food diet is there. uh, Extra virgin olive oil, omega-3 levels based diets, and polyphenol diets. We will be covering all three because it has got the maximum evidence and the medical nutritional benefit, though the remission and other things are far limited. Low energy diets, it has gained the momentum. It has got lot of studies coming up in 2024. Lot of publication have come, and the that is the redirect trial and direct trial, they have established the role of low energy diets in the reversal as well as the control of therapy. Ketogenic diets, they are again getting very good response, and it is being practiced by supervised patients in India, and they are giving good results. Intermittent fasting, it is old age process. There are many forms of intermittent fasting. Gradually the data on this is also coming up. So what the best suits for your patient, you have to adhere and then move ahead. Mediterranean diet, as we talked about, it has got many benefits, such as the HbA1c reduction as high as zero point 0.3 to 0.53. You can understand many of the drugs also achieve the same level. Fasting glucose reduces as high as 15%. You can understand 15% reduction. Most of your patients are euglycemic. Yeah, HOMA-IR, insulin resistance decreases. Insulin resistance improvement is as high as 27%. And then after, the benefit without weight loss, that is the very good thing. The people are averse to the weight loss, and they are the ones who benefit with that. So what does it offers? It offers the insulin sensitivity and decreases insulin resistance. So there are two benefits, and both of them are given to your patients. Mediterranean diet molecular mechanism, we will go one by one. And the polyphenols, they are AMP kinase activation, includes glucose intake. Extra virgin olive oil compound, again they have got better endothelial function. Omega 3 are associated with high anti-inflammatory effect, particularly your patient with high CRP, hepatosteosis, and they can be a better option. Gut microbiota, dietary fiber inclusion, butyrate production, and then after insulin sensitivity. Last but not the least, which is getting the momentum of the year, is the GLP secretion. What is there? There are more nuts and the fresh vegetables. They tend to cause the increased GLP-1 secretion, and then after better outcome in the diabetic care. So this is a busy slide, I understand, but I had tried to copy so that the consolidated view you have to have. The fiber related has got the improved insulin sensitivity, systemic inflammatory response, betterment in the TG and HDL. Polyphenols are more concerned about the systemic inflammation prevention and endothelial cell functions. The other monosaturated related are with the also present with the benefits of beta cell function. So this is the three major groups we will be talking about. The phenol groups, polyphenol groups, what do they do? They increase the AMP kinase activation, increase glucose uptake, better insulin sensitivity, and decreased insulin resistance. All these are there. So what are the ingredients? There is the olive oil, fish and red wine, which is included, and then fruits, vegetables, whole grains, legumes, and fermented dairy is advocated in this. These are the common ones which is practiced. Extra virgin olive oil. This is again getting the more and more popularity after the British Pharmacy Journal has published the meta-analysis in which they have found that the oxidative stress reduction was as high as 70% and the endothelial function has improved dramatically. So this is particularly the groups with the family history of early cardiac dysfunction, metabolicity, when they are obese plus the metabolically deranged, and then after the family history, they should be offered extra virgin olive oil once, and the patient who fits in should be continued on it because the benefits are far higher than the other one if carefully chosen. Dietary fiber inclusion, what it does, it grows the gut microbiota, and then after what happens, that is the short chain fatty acids are produced, and they further to increase the insulin sensitivity, and these are the ones which is used in good number in different diabetologists. Even the manufactured microbiota are available for sale in certain countries. What they do, they decrease the butyrate producing species. They decrease the short chain fatty acid. They what is dysbiosis? Again, what is happening? That these all things which is happening in the diabetes is corrected with the good microbiota to the patients. Mediterranean diet molecular mechanism we have already talked about. One of the important one, addition of nuts and fibers, they are known to increase the GLP-1 secretion, and then after there is the host of benefits, that is the these people have got the increased insulin, and they also have to have associated weight loss. Low energy diets, that direct trial which has come up, what is it there? It has come to that direct trial is a very unique trial, directed, that is direct diabetes remission clinical trial. What they do, 12 weeks of diet replacement and gradual introduction. The key mechanism was proposed was that it was decreased hepatic and pancreatic lipids, decreased lipotoxicity, B cell recovery was noted. This is important one. After the first phase and then first phase, insulin secretion improves. These all have been deliberated in the Nature Diabetes, that is 2024 Predimed trial, and what they have come out of that, the low energy diets do have got the remission and control strategies how to go about it. Very low remission strategy, what is there, they have got the doses, food doses which are far lower, but what is there, this danger sign is there. You have to give these people adequate therapy only under the strict supervision. I have submitted it for the benefit. The slides looks little different, smaller. But what you find, the in low energy diet groups, what is there? There is 8 to 1200 kilocalorie replacement. Very in a low energy group, what is there? 800 to 850 only. That is very low. What is the benefit? They have got the better adherence. Surely they have got the low fatigue and delayed control and more adherence. Key challenges are there. They have got the slow weight loss, gradual control, and some of them don't get remission also. But in VLDL group, what is happening? You are giving these people restricted that there is a significant reduction in the belly fat, there is significant reduction in the insulin resistance, and there is the quick remission, and these are the benefits. The key challenges are they are cumbersome, they have to be monitored, good motivation is required, frequent monitoring is required, and these all makes it little different for the implication. But if you have to choose motivated patient, willing for supervision, a good dietitian available, the VLED has got better benefits. This article which has published, it has given a host of benefits. I recommend you to kindly visit it, and it will give you a good idea how to go about it and how these diet, low calorie diet, have really made difference. Ketogenic diet is again an important methodology to reduce the medical glycemic load, improve the medical outcome, and they are ones which are now practiced all of the day. There are three, four types. I will come to that, but the key benefits are it improves the decreases insulin resistance. It also decreases ectopic and liver fat. It decreases hyperglycemia, and then after there is the what is the requirement? They have required the higher fat and moderate protein based diets, and there is energy reduction is optional. We will come to that. Three types: iso caloric and low caloric and otherwise. So the main issue is you have to give adequate protein and the fat, the ketones have to be produced, and then the insulin resistance decreases, sensitivity increases, and other thing. So what is the key benefits? The weight loss is there, reduced visceral fat is there, and reduced liver fat is there. So there is the multiple benefits at the this end. Glycemic benefits, there is the lower fasting glucose, lower postprandial glucose, lower HbA1c, there are there. Potential risk is what? There is the micronutrient deficiency, particularly in certain group of vitamins, and long term adherence is a challenge. And when you come to the need for supervision, it also requires supervision, but and careful supervision in which the low calorie ketotic diet is prescribed. The clinical outcomes, it improves the HbA1c, it improves the glucose control, it improves the rate of progression towards the complication, and last but not the least, it is a short term measure with longer benefits. So that is why ketogenic diet should be discussed with your patient. If your patient is willing, why not offer it? Ketogenic diet patterns, standard ketogenic patterns, what is their common very low carbohydrate, 70 to 80% of the that is the fat, 20% protein, only 5 to 7% of the carb. The clinical use in type 2 diabetes, particularly broad-based regime. The cyclical ketogenic diet again is practiced. There is the small period it is given, 5 days, out of 5 days, 2 days carbs are permitted, and rest days you are not. So what it causes? It stimulates the metabolic benefits, re-stimulates and re-stimulates. In rat experiment, it has been found that this is a more effective way than the standard one. But the human large trials with convincing evidence are far, far less. Targeted ketogenic therapy, it is now call of the day. Many of the centers are practicing. This is a standard ketogenic diet with multi micronutrient supplementation. 20 to 50 grams of carb maximum is given, and rest is only fat and the proteins. The use in that, there is minimal type 2 diabetes. Then after the other metabosity, and key benefits are they support the long term. It is given accepted therapy for most of the US based insurance companies, and the challenges are it requires supervision, targeted therapy is there, so that is why frequent call to the doctor is important. So these have got the benefits. Coming to the types, classification and efficacy, so what we note that all reduced at least ketotic diet by the HbA1c by less than 1%, and fasting plasma glucose at least 25 milligram. You can see this is the data again from the American Diabetes Association, American College of Endocrinology. They all have validated, in European Diabetes Association, all have talked about it. So coming to the types of diet, isocaloric ketotic diet, in which there is the carbohydrate is 50 grams per day, but they are eucaloric, means you are giving them at least 20 kilocalorie per kg body weight of that. So what is happening there? They have got the slow burning, and there is the challenge. Low energy ketotic diet, again they have got the same carb, but the total calorie is given is 7 to 800. And in very low energy ketotic diet, what is there? Still 100 kilocalorie you are cutting edge. So what are the benefits? The benefits are they got the quicker weight loss, better control, and earlier remission. These all are known facts. What is the molecular mechanism? The oxybutyrates are reduced, anti-inflammatory markers are there, and there is greater insulin signaling by AKT pathway. Then the hepatic lipogenesis is reduced, and lipid catabolism is activated, and autophagy causes the decreased oxidative stress. This is documented, this is evidence based, and that is why these molecular mechanisms work in synergy, and that is why better outcomes have been reported. Coming to the other group of treatment, that is the intermittent fasting. It has gained the good scientific background. What are these? One is the 2 days in a week energy restriction is there. And how much is the energy restriction? At least 25% of total energy requirement. So that is there. What is it causes? It decreases the HbA1c, improves the medication reduction, and it helps in the earlier control. Alternate day fasting is done. Every 24 hours you give liberal calories, and next 24 hour again you reduce the calorie by 25% or even less. So what is happening? There is decreased fasting glucose and increased quality of life. Here there is the patient is knowing, and he plans the calorie to the advantage. Time restricted eating, again 8 to 12 to 8 hour window is aligned with the circadian rhythm. And then after, what it is benefits, it helps in the postprandial reduction. And total calorie restriction, that is advantage is sustainable long term growth. No calorie counting is there, but however the long term monitoring and commitment is required from the patient. So coming to all three regimes, four regimes, we will understand how they work. And because this was the one which is quite practicable, I will request you to kindly go through. That is, the first is the 8 hours, 8 hours of abstinence from food, and 16 hours of abstinence and 8 hours of intake. So what it causes? It heightens this insulin sensitivity, fat oxidation, and decrease body weight and body fat. And what is the problem? Problem is the compliance, the hunger, irritability, dizziness, palpitation. People who are driving, working actively, they have history of hypoglycemia also. So these are the challenges. 14-10, again it is the practiced 14 hours of abstinence and 10 hours of food intake. Again it has got the beneficial effect in the body weight, improves the HbA1c, increases the body composition, lowered blood pressure, decreased lipid, and associated the cardiovascular rate. So what is then? There is the disrupted social eating patterns. These are the people have got the more complication, social rather than the actual metabolic. So occasionally dizziness, so occasionally abdominal pain, and sometimes This abdominal pain translates into vomiting, and somehow time the events there is the hypoglycemia. So this is the second one. Coming to the second regime, quite done. 5:2, 5 days of non-fasting and 2 days of fasting. Again, what it does is do, it improves the HbA1c, lipid fasting glucose, and quality of life. The fasting elevated occurrence of hypoglycemia, and it has caused the reduced medical requirement, and sometime the non-fasting days they tend to have compensatory eating. Then the benefits what you have derived in fasting is lost. Alternate day fasting, it is mostly done, and what is there, one day full meal and next day 25% of the total energy requirement, and alternate day. This is very very practiced, and many of our patients, elite patient interested in medical nutrition therapy, vouch for it. And how does it benefits? It increases body weight, waist circumference, systolic blood pressure, and plasma fasting glucose. This has got minor effect, that is fatigue and headache, particularly on the days of fasting, they report. So what are the molecular mechanism? That is the lipolysis leading to beta hydroxybutyrate, AMP kinase related activation, decrease mTOR, and increase autophagy. If the fasting is more than at least 12 hours, it does not improve that. And it improves the gut microbiota uh, diversity. It also increases the short chain fatty acid production, and if the circadian alignment is there, it improves the metabolic memory, and then after the other benefits. When we come to the molecular mechanism, again a busy slide, but what is then? It is multiple way it is affecting. And what are the three things it is doing? In decreasing the insulin resistance, increasing the lipolysis, and then after insulin sensitization. These all benefits are far there with the intermittent fasting. What does we do? We have got the four mechanism. All four are equally important. They are all evidence based, and they have got the goods and bad. What you have to do? There is no one shoe for all the patient. The medical nutrition therapy has to be individualized, and that is why to learn what is their Mediterranean diet, small weight loss goals, focus on the insulin sensitivity and inflammation control. So, what is the four things you have to do? Lean ones. They are the ones in which you don't want to have a big weight loss goal. But who are obese, the best is the low energy diet and very low energy diet or ketogenic ones. Moreover, these people require the psychological support, moral support, and then after the observation, the compliance diary, because they are difficult to treat. Integration of the pharmacotherapy with the medical nutrition therapy, it is the call of the day. The results are far better, particularly with the GLP-1 agonist. And when we do with that, we have to think about the glycemic target along with the caution on the muscle loss. So these all have to be individualized. We have got lean one, we have got the obese one, and we have got the people who have the challenge of muscle wasting. So what are there anything more to do it? There are a host of drugs who are adjunctive drugs, and this is the common one I will discuss. And adjunctive treatment of medical nutrition therapy. It may come as the short note, so I thought I must elaborate it in the benefit of postgraduates. Alpha lipoic acid, it improves the insulin sensitivity, decreases the oxidative stress. It is also used in the chelation of the heavy metals. It has got good anti-inflammatory effect. It is used for the Parkinson and Alzheimer neuroprotection. What are the doses? 3 to 600 milligram per day in divided doses. It is available in India and you can easily get it. Barberin, it is the multi-drug interaction is there, and this drug has got multiple sources also. Well, how does it help? It improves the glucose uptake, and then after AMP kinase associated glucose metabolism. The doses are 500 to 1500 per day in divided doses we give, and it does improve the HbA1c, fasting and PP at least improves significantly. Chromium ones, it is published. There are meta-analysis there. The chromium deficient people have got the insulin resistance, and if the chromium is supplemented, they improve the HbA1cs very, very significantly. The common sources are the lean meat, egg yolk. This chromium supplementation not only improves the glycemic control but also help in the dyslipidemia management. The doses to start with is generally 200 to 1000 micrograms based on the person's serum chromium levels. And usually, if you start replacing, there is the wonderful glycemic benefits. Cinnamon, this is the one which is available in all household in India. It is reported to have some common toxicity, particularly in the people who are on the thrombolytic therapy, that is the uh, therapy, anticoagulants. What is the active thing? This cinnamaldehyde. What does it help? It increases insulin sensitivity. It is good antitoxicant. The doses is very variable, and doses are 1 to 6 gram per day. Means at least you have to take 2 teaspoon a day. But this is not the therapy. It is only adjunct. It has to be given with the conventional therapy. Fenugreek, you all know, there is a meta-analysis which is available. What it says that the fenugreek addition to the other OHAs and the other therapies has been far beneficial effect. It has been proved beyond the reasonable doubt. This help. The doses are 1 to 20 grams. There are varied type of uses. There is roasted fenugreek powders is used, that is the soaked fenugreek seeds are used, and these all have got the benefit which is recorded. What is the benefit? How does it do? It increases insulin secretion, decreases fasting blood glucose, HbA1c, and it has got the very important one, LDL and TG reduction. Even your patients are not responding, adding on therapy is also advocated in many of the guidelines published by India, and decrease carbohydrate burning further to decreases the glycemic load. The incretin and MNT therapy, what is the best practice? People are increasing the Mediterranean diet with the GLP-1 inhibitor, particularly tirzepatide. There is lot many articles are there. Three articles they have already quoted. What is the caution? The people with low energy diet and very low energy diet, if you give with the GLP-1, the lean muscle mass is lost, and that is why you have to add on increased protein if you tend to use it. Warning: ketogenic diet and SGLT2, if you give, there is a serious but rare. It is serious but rare risk of euglycemic diabetic ketoacidosis, and mostly it is very difficult to treat and sometimes fatal also. So what is there? The monitoring, close follow-up and assess muscle mass, muscle fat ratio, and then after you decide, and you have to add on with the MNT, medical nutrition therapy, and incretin based therapy. How to go about the medical nutrition therapy? This is the question often asked in Viva for the postgraduates. All five steps you can understand and keep it on your sleeves. Nobody can fail you, but and also you will be doing more good to your patient. First is you have to assess the diabetes duration, weight status, comorbidities, and preferences. All four are important. In preferences, what are the level of social support is also important. The preferences not only of the person, of the society, the family he comes from. Choose the dietary approach based on patient phenotype. The lean patient should not be given the same as the that medivosity patient. Registered dietitian for personalized planning is important, because unless one or two ingredients are misunderstood, the whole benefit goes out of hand. Monitoring required, particularly these three are important. Medication monitoring, very important. Adherence monitoring, important. And weight is the neutral which always says the truth. And last but not least is the HbA1c. In newer guidelines, there is rule of fructosamine also coming up, and AGE estimates are also available. But for us, mostly HbA1c, weight, adherence, and medication are important. What is there? More adjustment of the long term sustainability based on the response. It is very important. Unless response is monitored, every 2 weeks you meet them, you assess them, assess the adherence, you assess their motivation to continue, you will not be able to achieve the long term benefits. So that is very important in medical nutrition therapy, that motivation, adherence, compliance, and further adherence, then only you can achieve the whole thing. A short term adherence may be due to challenge. What can be? That is the weight loss, appetite suppression. Long term, what is the approach? Individualized support system. 2 3 people join. It is something like Alcoholic Anonymous, wife joins, and like that they can be there. Regular dietitian follow up is important. Behavioral modification, very important. Family informant, that is the paramount, and we must be told with that. And telehealth options, in case of any emergency, there should be a scientific help available, guide him what to do and when to do. Now, very important thing what we have to understand, which one are the three things we have talked about. We are concerned about the HbA1c reduction, weight loss, and remission. The Mediterranean diet reduces the HbA1c, weight loss is variable, but remission is very less. LVD, low energy diets, and the very low energy diets, HbA1c reduction is highest, you see 1.4%. The weight loss is significant, at least 10%, 15%, and remission is again variable based on which regime he follows and what was the his metabolic parameter, particularly waist circumference, weight, and the lipid content. Ketogenic one, there is the significant weight loss, particularly the very low energy keto ones, not the common one. That is isocaloric, no. Again, they have got the remission, they have got the HbA1 reduction. The intermittent fasting, particularly the 5 is to 8 or alternate, have got the better outcome. And what is there? There is 1% reduction, weight loss is moderate, but remission is variable. Very, because all four strategy have got the different level of appetite suppression, different level of the lipid burning, and different level of thing. So where are we? We are requiring a good long-term adherence strategy. This is, we are knowing the science, we are knowing the outcome, but how to implement a medical nutrition therapy adequately, having the registered dietitian qualified and motivated is far far less. Gut microbiota marker of dietary response prediction, this is the thing which is growing. There is lot many articles published, and gradually this can be manipulated to the advantage of the patient. Circadian rhythm optimization in MNT protocol. This is important. These in which the more work is to be required. Personalized genetic and metabolic phenotype based therapy. This can be done. Particularly, three important genes have been identified which are associated with diversity. If they are there, the more directed medical nutrition therapy has to be done with a stricter adherence and better compliance monitoring. Integration with the novel pharmacotherapies definitely has to be done, and health equity in diverse population, particularly in country like India, where we have got the very challenging situation. In metros, they are the host of doctors, and their remote places, none of them. The key takeaway is कि medical nutritional therapy is the personalized diabetic care. It is the personalized diabetic care. You have to understand. There are multiple evidence-based dietary approaches. Mechanism involved is the multifold. That is the insulin sensitivity improvement, decreased inflammation, improvement of microbiota, and these all three, if they combine, the results are far better because metabolic homeostasis is more forthcoming. Personalization is important, patient phenotypes derivative approach, and last but not the is important to be ignored is the adherence, because it requires the multidisciplinary approach, sociologists, psychologists, doctor, dietitian, they and family members, unless all aggregate to achieve the MNT is a challenge to be administered, but it is a doable option with very few side effects and very good metabolic effect. These are my references. I am really thankful for the opportunity by given to my postgraduates thinking of their exam. My key suggestion is epidemiology. You must write the particularly direct trial is important. The four strategies you must know, at least two strategies in each of the type of diets you must know, and then after the comparative, if you can produce, the examiner will be far happier. And last but not the least, your own conclusion is important, because your examiners will be from your call university, they know the local problems, and if you talk about that, it is far important. With this, I feel I have tried to give you an answer to a long question which is quite important. My acknowledgements are my family members, my staff members, and children. Thank you. References are available on the Aratai number. If you want anything, you can definitely call upon. We are ready to help. God bless. Best wishes.